Hi, and thank you, and welcome to today's session. My name is Carol McClay, and I'm going to be your moderator today, and I'm very pleased to welcome you to session 3600, Being Heard, the IP and the Organizational Structure. This presentation is going to focus on the IP's contribution to a healthful workplace, culture that reduces barriers to the implementation of evidence-based practices that will lead to improved patient outcomes. And I would like to introduce you to our speaker today, Janet Glowich, MPH, MSN, and PhD candidate, is with the Northrop Grumman Institute. The project Let Me Go Potty, I Don't Want a Cotty, is the capstone project done in collaboration with the AHA, HRET Project Protect Stop Cotty Fellowship. Thank you very much.
Thank you. The project with the COTI is one that we did last year with a collaborative, a AHRT collaborative, and that was a popular title. So I'm one who was also expecting a room of about 5 to 15 people, so thank you all for coming. And what I really am hoping is to encourage you when you feel like you might not be heard, and also to encourage you to stick with it when times are tough, because it's not always easy being an infection preventionist. And as I was preparing this presentation, my husband and I went out and we bought this little specially engineered vacuum cleaner. And he loves his tools, and so it wasn't completely engineered the way he liked it, so he redid the tool, and he got it so that he just couldn't wait for me to use it. So to help him out a bit, I spilled some quinoa in the pantry, and all the little grains, they went all over the pantry, and my husband went and brought me the vacuum cleaner and said, "That's going to take you a while to clean up." So I was not particularly civil when I heard that. And then I started laughing because I realized that I was experiencing the theme of this presentation. How do we communicate in a way that people will hear us? And I honestly have said those words in the hospital. This is going to take a while to clean up, and we want to be there to be helpful and to communicate in a way that gains compliance and adherence and shows that we're a team. So no, my husband didn't really help me clean up, but he did make the tool, and it took me a little while to appreciate that his tool was very nice. So the objectives are to identify the attributes of a healthful workplace environment, to discuss collaboration to build infection prevention, competency, and to identify methods of communication that inspire change. And I did want to take a second just to place this within the APIC competency model. So this is really a leadership and program management presentation. And I want to just say for a minute that the CIC credential, I've heard a little debate about I heard a state health department asking how can we convince IPs to become credentialed, and I just want to say that it is the one credential that shows that you have a baseline knowledge and competency in infection prevention. And this presentation may be a little basic for some of you, but I hope that it's helpful. So, organizational culture. We know that we need to understand organizational culture and change it when it hinders performance. And changing culture is a difficult thing, but culture is made up of all of us. And I heard a presenter one time describe culture as fish in the fish tank. The culture is the water that the fish are living in. We, though, as infection preventionists, have a lot of impact on the culture that our healthcare providers are living in. And we can influence it, and we do have the power to change it through our attitudes and through ways that we lead others. We don't have direct evidence linking leadership to infection rates, but there are consistent themes that have been identified in qualitative research. So you can think about these leadership traits that assist in preventing infections as attributes that you might want to have. But you can also think of those things that expert IPs see when they walk onto a unit. So have you ever walked onto a unit and just had the sense that This is a unit that is brewing an outbreak. Yeah, right? You can see it brewing, and expert IP can see it all happening. And what is that IP seeing? So sometimes they're seeing that the leadership is reactive. A reactive leader puts a unit at risk for increased HAI, or a laissez-faire management style where everyone does as they please and they only get a response when things are not effective. Failure to assign responsibility. I think someone was talking this morning about recognizing that it wasn't assigned who cleaned different equipment, and so nobody was cleaning certain equipment, or to maintain accountability. Also, a wide span of control. So when you have that senior leader who's over 15 mid-level leaders, I know there was one mid-level leader at an institution I was at that had to do 250 employee evaluations. So it was very difficult for that mid-level leader to maintain accountability among her employees. But leadership traits that assist in preventing infections are that proactive, positive, visible, supportive of change, having clear responsibility and clear policies. So when you're rounding and when you're on that unit perceiving whether an infectious outbreak is brewing or not, you yourself are being a proactive and visible leader. So we also know that infection prevention is related to capacity on the unit. So it's affected by complex management issues. Research has shown that nursing staffing ratios are associated with HAI. So when you have lots of patients and few nurses, at one point in time, I heard a nurse say it was okay to accept extra patients in the NICU because they're little, they don't take much room, but crowding in a NICU is a very bad thing, right? High occupancy. So when there is crowding, or when, I heard a couple of facilities today talk about being older facilities with semi-private rooms and high occupancy, then you see rates of CDI go up. And just that one other thing that an expert infection preventionist can sense is that feeling of being overwhelmed by the staff. So stress and chaos are associated with poor prevention practices. We need strong leadership at the unit level and above, and this is a prerequisite to prevention improvements. So infection preventionists have experienced shifting boundaries and role uncertainty. And this also is from qualitative research that was done by Conway in 2013. And they talked about some changes in accountability for HAI. So infection preventionists felt pretty good when personnel on the unit own their own data. Is that something that you feel good about? And sometimes people on the unit can drive change. So that was helpful to infection preventionists. They appreciated the increasing engagement of hospital executives. But linking reductions in HAI to personnel evaluations and bonuses meets mixed reviews. So what do you think are some of the problems with linking reductions in HAI to bonuses or personal evaluations? Yeah, a kind of conflict, arguing about case definitions, trying to get out of HAI because if we go over a certain limit, we won't get our bonus. So that was met with mixed reviews. It creates buy-in, but it can also put some barriers in your prevention measures. And then many IP departments have been subsumed by the quality department. So this places a layer between the IP and senior leaders. And that can be a good thing. It can be something that makes it more difficult to implement change. Infection preventionists and quality departments use differing vocabularies. So the infection preventionist might say we have a point source outbreak in our ICU related to CLABSIs, and the quality leader might say we have special cause variation. So they're saying the same thing, but it's a different vocabulary, and it can make it more difficult to communicate that something actually needs to happen. And then differences in formal titles can influence meeting invitations, visibility, and a seat at the decision-making table. And that's really where this presentation came from. I was talking with Carolyn Gould, who presented this morning, about what happens when IPs are coordinators, but the nursing leaders are managers or administrative vice presidents. You may not be invited to those meetings. And in that case, you really have to advocate for yourself. And you need to be at those meetings when you go, even if they're not talking about infection prevention issues, because you need to be appraised of what's happening in the facility. So this is an actual infection prevention action plan that was submitted by a unit that was dealing with an infectious issue in a high-risk unit. And the facility was working with their state health department and putting together an action plan. And so what I wanted to show you was where they listed infection prevention. And I think as we go through this, you will see why this facility might have been having some problems. So the first opportunity for improvement that they identified was that they wanted to enforce procedures to ensure all who enter the unit are free from symptomatic illness. There's a request to dim the lights for the PowerPoint. And they made the person responsible for that opportunity for improvement the infection preventionist. That is an inappropriate role for the infection preventionist. Does that sound outdated to you all? It sounds outdated to me. And of course, you know that you don't have personnel in your chain of command. Enforcement is not really something you can do, and you're certainly not going to be on the unit all the time to enforce that kind of measure. They wanted to ensure ongoing staff competencies specific to the unit. And in that, they have the annual cleaning competency. They assign that to the clinical educator and the unit manager, but I would say that the infection preventionist has a lot to offer when it comes to staff competencies. They wanted to implement evidence-based practice. So they were going to create an order set for blood and stool cultures, and they were going to restructure nursing care. And they assigned that to the medical director, the care coordinator, the unit manager, and the service line director. We have a lot to offer when it comes to evidence-based care. We have the subject matter expertise related to the guidelines. And then they wanted to minimize contamination in the environment of care, and that was assigned to the manager of environmental services and risk management. The IP is absent from that. And so, like I said, you'll see when we get to the end why, we didn't feel really great about this action plan. Ongoing surveillance and reporting, and this really shows you that this is an IP and a facility that was struggling. The ongoing surveillance and reporting of these infections to the state health department were going to be overseen by the chief medical officer. Right? So that tells you that they're threatened, right? They really don't want to report. And for us, that's a red flag that, the IP needs support. And from the CDC's perspective, we are here to support IPs and to help you have your voice so that you're heard. And we think that you have a role in each one of those opportunities. On the next slide, I downloaded this from catheterout.org. And catheterout.org is talking about CAUTI prevention. And these are the personnel and the roles that should be involved in a CAUTI prevention team. So here you see the project coordinator, which is the infection preventionist. Now, if the infection preventionist were the coordinator on the last plan, that'd be awesome, because then the infection preventionist would have a place in all of those, each of those roles. But that is an appropriate role for an infection preventionist. And then instead of enforcement, assessment and evaluation are appropriate roles for the infection preventionist. So there's a big difference between enforcement and assessment and evaluation. We can offer real input if we're assessing and evaluating implementation measures. I did want to take a minute. I told you that I didn't respond civilly to my husband when he told me it was going to take a while to clean up the pantry. This is a fairly new statement from ANA, and they said in their position statement on workplace incivility, bullying, and violence that it's important first to recognize the existence of harmful actions taken and not taken in the workplace in order to eliminate them. And so I personally haven't seen literature on bullying in the infection prevention arena. but I believe it exists. And I wonder how many of you have had eyes rolled at you. How many of you have had things said about you? I even think to the point of when you walk on a unit and you hear infection prevention's in the house, hide the contraband, that is a form of incivility and even bullying. I was interested in a certain type of bullying that's called mobbing, and that occurs, well, first of all, what group do you think is most likely to participate in mobbing, which is when groups strive to maintain mediocrity and compliance with the status quo? Where in the hospital do you think you will find that? Nursing. And did I hear operating room? Yeah. And so what's funny about it is the reference that I had on mobbing came from AORN's website. So I think they recognize that too. I was talking with an IP at one of the dinners the other night, and she said that you just never know when you're going to run into the fist. And I thought that's a really, accurate description of what it feels like sometimes. And so I'll tell you that I think I enjoy conflict. Maybe that's something that we have to have in common, but it's an opportunity to establish a positive and respectful relationship. And that's crucial to preventing incivility, so we never respond in kind. The infection preventionist who said that you never know when you're going to walk into the fist, she also said that when you're implementing change, you might hit them with a velvet fist. And so one of the ways that I've approached that is I want to be that third grade teacher that the kids just hate at the start of the year, and then they love at the end because they've grown so much and learned. And then the kids get all the credit for, not that we're teachers, but we really need to have the backbone to stand up and the personal integrity to be kind in the face sometimes of incivility. If it's very severe, then there are things that you need to do with your human resources department and to solve that problem. But we can turn those relationships into good relationships. I really appreciate the American Association of Critical Care Nurses standards for a healthy work environment. And they say that these standards are interdependent and influence clinical excellence and optimal patient outcomes. And so they see true collaboration, skilled communication, authentic leadership, meaningful recognition, appropriate staffing, and effective decision-making as the elements of a healthy work environment. And I would encourage you to look at AACN's website and take a look fully at those standards, because it really describes what a great work environment is. And I know in our ICU, we had a fairly unhealthful environment related to some of the care that was being given to patients on ventilators. We closed that ICU to intensivists. The nurses developed a really wonderful relationship with those physicians, and our VAP rates fell in response to that. And the nurses were the first to say it's because of the communication and the collaboration and the healthy work environment that we've been able to establish. So we are going to focus on collaboration and communication. So this is Rhonda Cochran's slide. And she talks about collaboration. Collaboration is different than cooperation. And collaboration is an intransitive verb. So I had to look up what is an intransitive verb. Well, an intransitive verb is something that is doable. It's happening, we're working on it. It's not, Rhonda told the story about 5 frogs were sitting on a log. 3 decided to jump in. How many remained on the log? 5, because they just made the decision. However, if they had collaborated, they would have jumped in. So I was happy to find the picture of ants, because each of these ants is doing their part to move this. And I thought, really, if I had been on top of it, I would have gotten one of the NASCAR teams, the fueling teams during the race, because they're all doing their unique part to move the needle. So when there's true collaboration, every team member has a high level of personal integrity. The team members are competent, appropriate to their roles, and nurse managers and medical directors and infection preventionists are equal partners in fostering collaboration. And I really liked what the 4th grade student said. Cooperation is when we get along, but collaboration is when we use our uniqueness to make something great. I had a great experience in a collaborative effort that was offered through HRET, and that is where we did the project about the CAUTIs. And we did see a reduction in CAUTIs at our facility. And as I researched collaborative models, you could clearly see that diverse healthcare-associated infections in diverse settings have responded to interventions introduced through collaborative models. So from 2003 to 2013, collaborative models have brought tremendous success in reducing infections. And I would encourage you to go to the CDC's website or to Google the BSI, the Dialysis BSI Prevention Collaborative. And I would just point out that the tools used in that collaborative are posted on our website. And they have some great models for how to observe hand hygiene in dialysis. And I would also encourage you, when you have offers of collaboratives, whether they be through your ESRD network or through a health, a HEN or a QIO, any partner in prevention, if you can participate in a collaborative, take the opportunity. It really can be a lot of fun. My personal motivation for participating in the collaborative was to kind of tie my feet to the ground and make me focus on a single problem so that I wasn't spreading myself on, on many, many different projects. And it did. It made me focus on CAUTI. So collaboratives are powerful because they're additive. And also from qualitative research, themes that were identified were that collaboratives foster change. One of the things I would say about a collaborative is it's not necessarily the infection preventionist who has to be the active member. The infection preventionist can be a subject matter expert to an intensive care unit leader or to a nurse who's using a nursing ladder to bring change to the unit. So the collaboratives are a great way to develop champions. They standardize processes, messages, and metrics. Many collaboratives will ask for your NHSN data. That is just standardized data that helps judge change. You can engage your frontline staff, foster local implementation, assist organizational learning, have support resources and accountability, and ensures feedback and reinforcement. And collaboration spans the continuum. So I've seen this slide in a couple of other presentations, but one of the things I wanted to point out about this, in the CAUTI collaborative that I was in, there was a nurse who was concerned about patients with urosepsis coming from the nursing homes to her facility. So she reached out her hands across the street and helped the nursing homes understand how to prevent CAUTIs in their population and reduce the rates of urosepsis reporting or coming to her hospital. That's a great example. And in the future, you're probably going to see that the public health department may be a nexus, especially when we're dealing with carbapenemase-resistant Enterobacteriaceae and other resistant organisms. When they did some statistical modeling to create this chart, they showed that 5 years after CRE has appeared in 10 facilities, if we keep acting the way we're acting, 12% of the population will be colonized or infected with CRE. That's the same rate at which MRSA was found in surveillance cultures at the facility that I was at. But if we have a coordinated approach, we could potentially reduce that to 2% and have much better control measures. So moving on to communication. I heard some great communication in a presentation about Jedi mind tricks. Did any of you attend that? Yeah, she did some really artful communication. She talked about color and she talked about having fun. One time at one of the hospitals that I was at, we had problems with them removing the gel from the bladder scanners. So you'd find a bladder scanner to have that nasty gel on it. So we put out a message about jelly bellies and how you don't want that. You know, take the jelly and get it off of there. Skilled communicators focus on finding solutions, and I would say that they have fun. They protect and advance collaboration, invite and hear all relevant perspectives, call upon goodwill and mutual respect, and demonstrate congruence between words and actions. So, you get a call from the OR, and the urologist is saying, can I flush the ureteroscope with betadine right now before the procedure instead of reprocessing it? Right? So your answer is not going to change. The answer is no. But if you pause for a minute and call upon goodwill and take another's perspective, you can, okay, so it took me a year to call upon goodwill and consider the other's perspective. But first of all, this call came from the OR. So what does that tell you about this question? It tells you that the OR is saying no, and the physician is pushing, and so the OR said, well, okay, but you're going to have to ask infection prevention, you know? So they're asking for your support. Another thing that this question tells you is that the physician does not understand what high-level disinfectants are. He thinks that betadine is a high-level disinfectant, or he doesn't understand that this is an instrument that needs actually sterilization. And I was very happy to hear Dr. Ratala say in his presentation that the Spalding criteria will change, because we had a big debate about this is an item that goes through mucous membranes to a sterile area. So where does that fall in the Spalding criteria? So that'll be very nice for them to indicate that in the Spalding criteria. The other thing that was going on with this instrument is that it was actually already sterile. It had been sterilized, but it wasn't stored sterile. And so there was a press for time, and the urologist wanted to move on with the procedure, and he did not want to reprocess it. So it wasn't that it was dirty and he was going to put betadine through it. It was that it was already sterilized, but he didn't want to re-sterilize it. So it took a while to get that perspective. The correct response is always no. And then it's good to have a script. This facility does not vary from the manufacturer's instructions for use without formal written communication of updated FDA-approved processes. I talked to a manufacturer today, in fact, about another piece of equipment that required ethylene oxide. And one of the things I saw about that was that certain facilities had a lot of pushback because they no longer had ethylene oxide, so they were doing other types of sterilization that were not cleared by the FDA. That will always get you in trouble. It will always get you in trouble. Never stray from the manufacturer's instructions for use. And just so that you know, this call resulted in the purchase of additional instruments so that we didn't have that problem any longer. And then this slide, I actually stole from one of our infection preventionists, and I didn't ask Sue Sabasco if I could use it. I just stole it from her. But if you know Sue Sabasco, she's a former president of APIC. Our system was trying to improve ultrasound probe disinfection. So Sue used SBAR, which is a method of communication that we teach to nurses, but it's very, very effective for infection preventionists. And it's also effective when you have outbreak situations, but in this scenario, the infection preventionist is using it to encourage purchase of equipment. So she makes a very clear statement about what the situation is. Ultrasound probes are currently disinfected in the patient exam room, and this room lacks appropriate ventilation per OSHA standards. So there's clearly a problem. Then she provides some background. Intracavitary ultrasound probes require high-level disinfection between each use. So we have to continue disinfecting. A clear assessment. She identified that patient and employee safety is compromised by the lack of ventilation and mixing of clean and dirty areas. and then a very specific recommendation, purchasing a system that obtains compliance with regulatory bodies as soon as possible is recommended. She quoted the cost of the system and what it would take to place that system. And I not only stole this for my slide, but I stole it at the facility that I was at, and we also successfully purchased the system that we wanted to get. So it's just an example of a very clear way to communicate with administration what your needs are. Sanjay Saint talks about constipators and active resistors. So constipators are those folks who don't want to move. So I'll go back a bit, though, and start with active resistors. Active resistors are personnel who are highly invested and resistant to change. And the best example I had of an active resistor was a supply chain manager. So we wanted to purchase a certain Foley insertion kit, and this Foley insertion kit was it was labeled with the order that you use the supplies, everything to insert it and to secure it was included in the kit, and we wanted Urimeters in our emergency department so that we didn't break the system when the patient went to the ICU. The supply chain manager was not for that, and there was not going to be any headway with that. But when we, as a part of the collaborative, took our data to the supply chain manager and showed her that 100% of our Foleys in our ICU are broken systems and our CAUTI rate is too high, and we could fix this if they inserted Foleys with Urimeters in the ED, she bought in. And then when we also added the ICU leader as an effective champion, we had those Urimeter kits in our ED in a New York minute. It was very easy to implement. So she was an active resistor who was relatively easy to bring over to our side. Another example from the collaborative that I was in was an organizational constipator, and this was a nurse who was putting together her CAUTI team, and she selected interested people to be a part of the team, but then the chief nursing officer decided that she didn't want them to participate. She removed everyone from that person's CAUTI team and appointed people to be on her team, not necessarily people that were interested. This nearly killed the project. And actually, in that instance, a worst case scenario happened, and that was that the CNO actually was replaced and asked to leave, which worked out well for the IP, but it's an unfortunate thing for the facility and for the nurses who work there. Sanjay Saint says that when you're working with organizational constipators, you should engage the individual early in the initiative. And then he even recommends working around the individual. I really inserted provide every opportunity to improve or comply and document. When you're trying to recruit an organizational constipator who's not cooperating with you, your documentation may be needed. There have been times when we've made recommendations, or when I was in an acute care facility, we made recommendations. The recommendations were not acted on. Joint Commission came through. They asked for our documentation. When we provided the documentation, they sat down with the leadership and had a conversation about these are not infection prevention findings, these are leadership findings. So sometimes when I say utilize your external partners, you don't want to have to utilize your external partners, but your external partners can be very powerful partners to help you gain the footing that you need to have. What you don't want to have happen is you don't want to have just a verbal, well, I told them. You want to have that audits and feedback, your recommendations spelled out so that you can show that you have been working hard to implement change. And the worst case scenario is termination. We don't want that to happen for anybody or to anybody. Sometimes as an infection preventionist, I've told people that my least favorite part of the job is being the bad news bearer. I feel like I'm going to the floor and taking feedback that's not necessarily favorable. And I did find a study that was done a while back, it's from 1999, but they were talking with UPS supervisors about how they kept their employees motivated when they had to give them everyday bad news, routine bad news. They were giving bad news like, I'm sorry, I can't let you take that vacation, or we were late with this many packages. But we really actually give a lot of routine bad news. So we're going with feedback that's less than optimal. I'm not talking about disclosure of an adverse event, but I'm talking about preventing adverse events. So sometimes routine bad news can be considered impolite. Why are you calling me out on that? Why are you asking me to do that? Why are you looking at my central line dressings? Why are you checking out how many Foleys have broken systems? It can be considered impolite, but it's necessary. It's necessary to avoid problematic and severely negative feedback episodes. So UPS used strategic delivery. So one time when I was a kid, I did have a paper route, and I threw a newspaper up on a porch where there was a sleeping dog, and I thought I was going to lose my life. But I didn't. I'm here talking to you now. But we can't really let sleeping dogs lie. I do like the quote that Dr. Anderson gave in his presentation, where he said, Rolling Stones gather no moss, but they leave a lot of broken items behind them. So we're breaking down barriers to change. And we can preserve solidarity and teamwork by using the messages that Susan Dolan used. We're all in this together. It's a reflection on all of us, how we work together. And we want to reduce threats to autonomy and competence. We want them to have autonomy, and we want them to know that they are competent, but we want to change the culture so that it supports competence. There was a Cochrane review done on routine feedback, which I've also called routine bad news. And this graph at the top, you can see they started out with some bad news. Their compliance rate with their VAP bundle was only 33%, and their VAP rate was 30 per 1,000 ventilator days at the beginning of this. So that's bad news. The Cochrane review looked at over 100 studies, and they found that feedback was most effective when performance is less than optimal, and when the person responsible for feedback is a supervisor or colleague. When it's provided more than once, so as you can see on this graph, it was provided monthly for almost a year. And when it includes clear targets and an action plan. So it would be nice on this graph to see what their target was for their compliance rate, because I imagine they want it to be above 90 or 95%. And that what their target is for their VAP rate, because I imagine they want that to be low. But you certainly can see, even without those kinds of targets spelled out, that they made a lot of progress by providing that routine feedback. Carolyn Gould talked about the TAP strategy this morning, and as she outlined, it's a linear progression framework for quality improvement. So you may have heard about TAP as a report that you can run in NHSN, and it is that, but it's becoming more than that, and I'm really excited about where TAP is taking us. So it helps us target facilities and units, assess gaps, and prevent infections. And it allows us to take a focused approach to map excess HAIs, to have a concrete prevention goal, and identify specific gaps. You start by running the TAP report. And these how-to guides are on the CDC website. How many of you have run a TAP report? That's very good, very good. And I just wanted to make a quick point about the SIR compared to the CAD. So it's important to let your personnel know that the SIR can be used for comparison over time, and it's risk adjusted. The CAD, the cumulative attributable difference, is used for prioritization, and it's a snapshot of the number of infections which, if prevented, would result in a goal attainment. So the CAD is a prioritization metric. It is not, you should not put a CAD on a graph over time. The SIR belongs on the graph over time, but the CAD is used to prioritize units, and it's used to communicate a goal. When the TAP report is run, it really is a fairly complex report, I think. And if you were to give that report to your senior leader, they would have a lot of trouble making out what to do with it. I did put the yellow circle on there just to point out that the CAD should always be rounded up. So if you told staff that they needed to prevent 5.7 infections, doesn't make a lot of sense, but they need to prevent 6. So always round up. And then this also, Carolyn this morning called this the wheel of misfortune. But this is in our TAP guide, and it shows that the SICU had 5 CAUTI. And using the CAD, if they had prevented 4 of those CAUTI, they would have met their SIR goal. So 4 of the CAUTI in the SICU were considered excess infections. And there's some wording there that you can use with leadership. And then Carolyn also had featured the letter from Wisconsin to facilities, but the Wisconsin Department of Health distributed facilities CADs to them. Other states we've heard about have let facilities know where they rank as far as you have the most excess infections in our state. You are number 5 as far as excess infections go. So that's very motivating for facilities to take part in collaboratives. But I really liked what the Wisconsin Department of Health stated. They said the tradition of collaboration among Wisconsin hospitals is a proven method for improving healthcare quality. And the Department of Health strongly encourages you to participate in one of the collaborative HAI reductions led by, they named some specific organizations, but it's the Quality Improvement Organization. What the TAP is developing into is the actual focused assessment. So these assessments are also posted on the CDC website, and they're intended to be given to a broad number of staff in lots of different roles, mid-level, senior leadership, frontline providers. You can give them out as a survey if you focus on a unit where you've noticed an excess CAD. And then it takes them through the guidelines and the prevention measures so that the staff are indicating whether or not something is routinely practiced on the unit. So it begins with some yes or no. So there are some questions like, does your facility have a champion, yes, no, or unknown? If the staff don't know who the champion is, then you know that you need to help the staff recognize the champion. On these questions, the ones I've included here, these are Spectre questions, never really, rarely, sometimes, often, and always. Are patients with diarrhea, at least 3 unformed stools within 24 hours without a known cause tested for CDI? So although that may be written in your policies, it tells you what is the staff on the unit experiencing. What are they sending? What is their level of knowledge? When you do that, and at the time I did this presentation, the Excel worksheet was not posted on our website, but I understand that it is now. You can use fillable forms from our website, and those can be extracted into a Microsoft Excel spreadsheet, and it will identify your top opportunities for you, and that will help you focus your interventions on the needs of the unit and the responses of the personnel on that unit. Once you've done that, then we have 2 guides that are posted on our website, the CAUTI and the CDI implementation guide. And so we've collected tools from states across the United States, health departments, and facilities to help implement guideline interventions. So if you had an issue with hand hygiene, there are some hand hygiene resources. If you had an issue with testing, there are resources to help educate physicians about appropriate testing for CDI. There are some nurse-driven protocols for CAUTI that are posted there. So wherever you find your issue is, you can turn to those tools and hopefully find some tools that will help you. So in summary, we all know that reporting is required, but it doesn't teach prevention measures. It does, however, inform the need for collaboration and communication. And collaboration and skilled communication build credibility. We have assisted the AHA and the Health Research Education Trust in recruiting some folks into collaboratives. And one of the things that we heard over and over was that IPs are busy and sometimes you're suffering from initiative fatigue. So I would encourage you to choose your projects carefully but participate fully. And like I said, for me, I wanted to tie my feet to the fire and really focus on one thing. So you should do your risk assessment and choose the collaborative that you want to participate in based on your facility's greatest need. So I would encourage you to avoid fatigue by engaging collaborators. One of the things that helped me also in reading about followership, an author advocated for doing away with the term follower and replacing it with the term collaborator. And they said that collaborative leaders are seeking collaborators. That helped me because I didn't have to have anyone in my chain of command. I just needed to know who was going to collaborate with me, who was willing to buy in and move things forward. To help those who are collaborating with you, you can create standing infection prevention agenda items for members of collaboratives and encourage them to report to senior leadership on how they're doing. And then the monitoring and feedback that goes with the collaborative is really essential to move things forward. And just leading it back, it's a leadership and program management, influence, performance improvement, and implementation science. So collaboration and communication lead to improved performance. So thank you for your attention.
Thank you so much for that wonderful presentation, Janet. We'd like to open the room up for questions right now. And we'd like to ask that you use the microphones, please, and identify yourself. Any questions at this time?
It's not personal at the end of the day.
Maybe we could go ahead and turn the lights on, please. Thank you. Well, I would like to ask one question of you. So we talked a lot about mindful and healthful environments, and can you maybe share some tips with IPs if you're meeting a lot of resistance from your senior leadership and they're not giving you the decision-making autonomy that your position requires?
On that, I would really interact with, I would make sure that I was documenting what I was asking for. I would be using the SBAR communication. I would be making the specific requests and really looking for how that senior leadership responded. And then I would stay on it. One of the things I love about Kathleen Volman, she comes up with just the best one-liners to use with senior leaders. So when it came to IJ central lines, Kathleen Volman said, do you want your IJ and femoral, do you want your CLABSI from the stool or the drool? When I fed that line to my CMO, he used that with the physicians to discourage IJ and femoral central lines. So interacting with other IPs and hearing how they're communicating things, and that's why I love the Jedi mind tricks. She did a great job of just coming up with those one-liners. Very specific, pointed communication, I think, can help leaders.
So using a sense of humor.
A sense of humor.
Really seems to help.
Yes.
Are there any other questions for our speaker today? Well, thank you for coming. I'd like to close the session, and we'll see you at the plenary.